This conference will now be recorded.
Bismillahirrahmanirrahim. I welcome you all on behalf of Department of Ophthalmology, Gurki Trust Teaching Hospital, and LMDC Lahore in today's monthly clinical OSP meeting of Lahore branch. We start the formal proceedings of today's session by listening Tilawate Quran Pak. The first part of clinical meeting is comprising of the scientific session of presentations in which four postgraduate residents will come one by one and present their interesting clinical ophthalmological cases. So to start with, I like to invite Dr. Ahmed Yashar Khan. He is second year resident FCPS in our department. He will present his first case.
Bismillahirrahmanirrahim. Assalamu alaikum. The case that I'm going to present today is about a 11 years old girl who's a resident of Lahore and she is school going, sixth grade going girl. She presented to us in the IOPD on the 4th of Jan 2023. She had a red painless nodule on her right upper lid that had been gradually increasing in size over the past 1.5 months. The patient was in her usual state of health 1.5 months back when she started developing painless swelling in her right upper lid. The nodule was subsequently diagnosed as lesion and the patient was given conservative management. When the patient came to us 2 weeks after the initial presentation, she complained that there had been a discharge of pus and blood from the nodule, with size being decreased for the last 2 days. She also complained of a mass that was protruding from the palpebral fissure area. The patient had no significant medical history and she was not taking any medications at the time of the presentation. She also reported no history of trauma to the eye or eyelid. There was also no history of diabetes or hypertension in the patient. Coming on to the surgical history, it was also insignificant. Similarly, the past ocular surgery was also insignificant with no prior history of any kind of orbital infections, ocular surgery, or trauma. The family history similarly was also insignificant with the patient belonging to a middle class. Now we'll come on to the examination of the patient. First of all, her general physical examination was absolutely normal. The patient was well oriented in time, space, and person. Her lymph nodes, including both the submandibular and preauricular, were also not palpable. So, when we examined the patient and upon eversion of the eyelid, we found that there had been a previous nodule that was ruptured, and we could see the cavity with a tongue shaped mass with overlying thick cheesy discharge that was arising from the palpebral conjunctival side through the palpebral fissure. The nodule was noted to be about 1.6 centimeter in size. There was no tenderness on palpation, although it did bleed on touch. So the two side-by-side pictures of the patient when she presented to us 2 weeks after her initial presentation on 16th of Jan 2023. The first picture is simply of the nodule, while the second picture is when we touched it and it bled, as you can see in the picture. Coming on to the gross ocular examination, it was also normal except for a slight edematous feeling on the right eye of the patient. Similarly, the vision of the patient was also normal. Coming on to the slit lamp examination, there were findings of anterior and posterior blepharitis in the right eye, as well as a mass protruding from the right eye from the palpebral conjunctival side through the palpebral fissure. Other than that, the slit lamp examination was normal. Similarly, you can see that AC, iris, pupils, and lens were all normal with no any findings on the patient. After going through the examination and clinical findings and the slit lamp examination, we came to these three provisional diagnoses, which included ruptured clesion, pyogenic granuloma, and capillary hemangioma. And finally, based on the clinical findings and examination, a diagnosis of pyogenic granuloma was finally made. The patient was advised to undergo surgical excision of the lesion under general anesthesia. The procedure was performed, during which perfused bleeding happened when the lesion was completely excised. Now we'll go through some of the per-op pictures of the patient. As you can see that the lesion was clamped, cauterized, and excised from the base by the surgeon. And during the operation, perfused bleeding did happen, which was cauterized and later stitched. You can see the stitches on the upper lid of the patient from where the lesion was excised. So there were no complaints during or after the procedure. The patient was prescribed topical antibiotic ointment and was instructed to apply cold compresses to the eyelid if she felt any swelling and to reduce swelling and discomfort. This is the biopsy report of the patient. The biopsy sample was sent after being excised to the lab, and it revealed that the skin with the underlying benign proliferation of small sized vessel lined by the endothelial cells. And upon diagnosis, it was confirmed to be pyogenic granuloma. So the patient was called for follow-up 1 week after the procedure. The upper lid had been healed well, and as you can see, there was no evidence of recurrence. The patient was advised to continue applying the antibiotic ointment. So basically, what is a pyogenic granuloma? It is characterized as a pedunculated vascular lesion, and it appears as a fleshy red or pink mass. The causes may include stroma, surgery, and inflammation, and the treatment involves surgical removal of the growth along with any underlying tissue that may be contributing to its development. These two pictures, which have been taken from the Accusamen surgical pathology, shows the histology of the pyogenic granuloma. The first picture is basically just a low microscopic view of a pyogenic granuloma, while the second picture is a so-called capillary or vascular lobule, and the presence of this is almost always shows that this is a benign process. And these two pictures, they are basically the comparison between a pyogenic granuloma and capillary hemangioma. As you can see in the first picture, that the most distinctive feature of this is the so-called vascular lobule, which is central branching vessel, and it is surrounded by a hypercellular proliferation of newly formed endothelial and perithelial cells. While coming on to the capillary hemangioma, you can see epidermis and the lobules that have been separated by the thin septa containing clusters of thin-walled capillaries, as well as the capillaries that are lined by the single layer of endothelium. This is all. Thank you.
questions from the audience? Sir, the pictures which were shown in the last, these are from the book. It was sent as a mass, and the lab did not form the. Yes, sir. Yes, sir. Yes, we should have advised them from the uh, samples. Generally, they're not formed, sir. On every biopsy, they're not. Yes, very good suggestion, sir. जी. Thank you, sir. For the next case presentation, I like to invite Dr. Naila Hanif. She is MCPS resident in Department of Ophthalmology.
Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. I'm Dr. Naila Hani, President of Ophthalmology. Today I'm presenting a case in this clinical meeting. My patient Suhaib Ali, 18 years old male, resident of Gujranwala, factory laborer by occupation, came to the IOPD on 16th March 2022 with the presenting complaint of sudden painless loss of vision in the left eye since 8 days that was followed by in the right eye involvement after 2 days. Patient also have complaint of photophobia in both eyes since 1 day and redness in both eyes since 2 days. Headache was there since 2 days and painful oral ulcer since 15 days. My patient was in usual state of health 8 days back when he suddenly developed loss of vision in the left eye that was followed by decreased vision in the right eye. Loss of vision was associated with headache, burning sensation, and photophobia. There was redness in both eyes associated with reclamation. There was no history of fever, neck rigidity, and any neurological manifestation. There was no history of recent skin eruptions, no history of arthralgias, and no history of trauma. There was no history of pulmonary and coronary involvement. Urinary and GIT complaints were not there, and patient was non-diabetic and non-hypertensive. In his past history, patient have painful recurrent oral ulcers and 3 episodes in last 12 months. There was also history of painful genital ulcers on and off in 5 months. There was no relevant other systemic past history. Patient belongs to lower socioeconomic class. There was no significant family history. Personally, patient was non-addict, non-smoker, and there was no known history of IV drug abuse, and no history of indwelling Foley's catheters. There was no known history of sexual contact. Continuing our clinical examination, patient was well-oriented with time, place, and person, and general physical examination was normal. On gross ocular examination, patient doesn't have alopecia areata. Eyebrows and eyelids were normal. There was no ptosis, no proptosis, and eyes were orthophoric. On gross ocular examination, patient having bilateral best-corrected visual acuity 618 in the right eye and PL positive in the left eye, and light projection was there in all the four quadrants. The near vision in the right eye was N12 and in the left eye it was less than N16. Intraocular pressure on Goldman applanation tonometry was 12 millimeter of mercury in the right eye while it was 13 millimeter of mercury in the left eye. Pupils were round, regular and reactive in the right eye, but there was relevant afferent pupillary defect in the left eye, and color vision was normal in the right eye, but there was desaturation of red color in the left eye. Light bright sensitivity appreciation was normal in the right eye, but it was decreased in the left eye. Extraocular movements were full in both eyes. On slit lamp examination, patient's lids were normal, but there was ciliary congestion bilaterally, cornea was clear. In anterior chamber, +2 cells were there in the right eye and +4 were there in the left eye. Anterior chamber flare was faint in the right eye, but it was +3 in the left eye. Iris were normal, lens were clear bilaterally. In the vitreous, again there were cells, 2 plus in the right eye and +3 in the left eye. Continuing our clinical examination, on his fundus examination, there was right disc and macula were grossly healthy, while the left hazy view of the fundus initially and later on we found the left pale optic disc. As you can see in this picture, the disc macula is grossly healthy in the right eye, while there is whitish looking disc with blurring of margin, but the final details are uncommentable because of the hazy view. Continuing our clinical examination, we move on further towards the systemic examination. On GI examination, there were oral ulcers on both sides of the tongue. They were painful genital ulcers. CVS and CNS examination was unremarkable. We performed Petharzi test. Petharzi actually refers to the formation of papular or pustular reaction that appears 24 to 48 hours after pricking with a sterile needle. It was negative in our patient. This picture shows how to perform the Petharzi test. After Petharzi, we performed dermatographia. Dermatographia indicates the skin hypersensitivity that consists of the formation of erythematous lines after stroking or scratching. When we performed dermatographia, that was positive in this patient. As you can see here, this is the video. As you can see, as we stroke the patient with the toothpick, there was a pattern appeared that was the skin writing, what we have done on the patient. So it's quite obvious that dermatographia was positive in our patient. Completing the clinical examination, we offered some lab investigations include CBC, ESR, Montox, chest X-ray, serum antinuclear antibodies. Ocular investigation, we offered B-scan and OCT. His blood complete examination was normal. ESR was 16. Montox mycodot test was negative. Urine complete examination was also normal. With the help of rheumatologists, they advised a test that was HLA-B51 and it was positive in our patient. This is the optical coherence tomography of macula. As you can see in the right macular cube, all the layers of the retina are fine, but on the left side there is thinning of the retinal layers, especially temporal to the fovea. Optical coherence tomography of the retinal nerve fiber layer and optic nerve head was normal in both eyes. This is the B scan of our patient. This is the B scan ultrasonogram of the left eye of our patient, which shows the cells in the vitreous. They are more predominantly in the posterior segment. On the basis of our clinical examination, history, and investigation, there is international study group criteria for Behçet disease that includes the recurrent polar ulcers contain 2 marks, genital ulcers 2 marks, ocular inflammation 1, skin lesions 1, and pathargy reaction 1. If the score of the patient is equal to or more than 4, it would indicate Behçet disease. Fulfilling this criteria, our patient score was 6, that strongly indicate it was Behçet's disease. So our final diagnosis on the basis of history, clinical examination, lab investigation, and ISGBD criteria, it was Behçet's disease. We started our management topically with prednisolone eye drop, diclofenac eye drops, and cyclopentolate eye drops. Topical treatment could be adequate if there would not be the involvement of the posterior segment. But as the posterior segment was also involved in our patient, so we offered suprachoroidal steroid injection. Involving the rheumatologist, they prescribed the systemic medications that were oral prednisolone tablet delta cortical 6 tablets in the morning and 6 in the evening. So they were tapered off on successive visits. Immunosuppressants actually revolutionized the management of Behçet disease. So they prescribed immunosuppressant 120 milligram infliximab subcutaneously. Our patient has got 17 injections till yet. So on follow-up, in recent visit, his visual acuity has improved successively and it reached to 6 by 6 in the right eye and 6 by 18 partial in the left eye. This is the follow-up OCT macula of our patient. In the right macular cube, you can see the retina is intact, while on the left side, still there is thinning of the retinal layers on temporal to the fovea. Thank you so much.
Any questions? Ji, sir.
I think we agreed long time ago to keep the identity of the mission confidential. Instead of writing name, if you can write down X, Y, and Z, and that will be that's right.
Thank you, sir. Now we move on to our next case. The third case is of a patient which presented to us with vertical squint. And Dr. Mariam will come. She is second year resident and she will discuss us with the clinical features of that patient and the further management. So Dr. Mariam Khalid, please come here.
Bismillahirrahmanirrahim. I'm Dr. Mariam Khalid, second year postgraduate trainee FCPS at Gurki Trust Teaching Hospital and LMDC. My patient, 23 years old female, presented to us on 26th of July 2022 in the outpatient department with the complaint of inward deviation of right eye since birth. Patient was having inward deviation in right eye since birth. She was advised squint surgery at the age of 4 years but was operated at the age of 5 years. She is myopic and has been using glasses regularly. The patient has no history of diplopia. There is history of severe trauma to the right eye after first surgery at the age of 6 years. There was no history of any other recent illness. In the past history, the patient underwent squint surgery when she was 5 years old. According to her mother, after the surgery, her deviation improved. These are the pictures of that patient preoperatively and postoperatively when the squint surgery was done. After 1 year, her eyes deviated again as the patient has a severe blunt trauma on the right temporal region. There is no previous record of the surgical procedure that was previously done, no previous record of any repair after trauma to the right eye. This is the picture of the patient when she was 10 years old. The medical history she had no diabetes, hypertension, or asthma. The family history, the patient had no family history of squint. Her birth history was also completely normal. Coming to the ocular examination, the visual acuity was 6 by 6 in left eye with glasses, whereas it was counting fingers in the right eye with no improvement with pinhole. The color vision was normal in both eyes, and the intraocular pressure was 16 millimeters of mercury in both eyes. The slit lamp examination of the patient was completely normal, except that the scar marks of previous surgery were noticed on the sclera of the right eye. This is the pictures of fundus of the patient. The left side is completely normal, while on the right side, we can notice myelinated nerve fibers, the macular reflex is dull, and the fundus is myopic. These are the retinal crosses of non-cycloplegic retinoscopy that was done at 1 meters. On the right, we can see that the patient was high myope. On coming to the orthoptic assessment of the patient, her head was tilted towards the left shoulder, an ocular deviation of 10 degrees esotropia in the right eye, and left hypertropia of 15 degrees. The extraocular movements showed limited function of right superior rectus, and anomalous retinal correspondence was harmonious. This shows the head posture of the patient. Head is tilted towards left shoulder, face turn, and chin elevation. These are the pictures of extraocular movements of the patient, which show restriction of the right superior rectus muscle. To determine the weak or paralyzed vertical rectus or oblique muscle, Park's three-step test was performed. The first step includes the cover or uncover test, which shows that the left eye is hypertrophic, involving right inferior oblique and superior rectus and left superior oblique and inferior rectus. In the second step, the patient is asked to look on the right side and the left side on the lateral gaze movements. On the right gaze, we can notice the left hypertropia increases. So that means that it might be involving the superior rectus of the right eye or in superior oblique of the left eye. Third step, which is also known as Wachowski's head tilt test. The head is tilted to the right side and the left side. On right head tilt, left hypertropia increases, indicating right superior rectus palpable. The binocular functions of the patient were also done. Frisbee test and Titmus dye test were done, which showed that the stereo acuity of the patient was grossly reduced. This is the picture of force ducton test of the patient that was done intraoperatively, and it was negative. Here is a video of force duction test being done intraoperatively, which came out negative.
बिल्कुल एंड तक जा रही है इधर
History and the clinical examination that was done, our clinical diagnosis was post-traumatic right superior rectus varices. The management plan in our minds was to perform a surgery after GF fitness, and our plan included right inferior rectus recession or right superior rectus resection. What we did was, under general anesthesia, right inferior rectus recession of 16 millimeters was done with marginal myectomy. These are the pictures of surgical procedure being done. This is the picture of the patient on the first post-op day. These are the different pictures of the patient in different gazes. On her first follow-up, which was done after 1 week, this is the follow-up of the patient after 1 month. Slight hypertropia in the left eye is still being noticed. That's all from my side. I would like to ask our worthy seniors from the audience if they would want to add up what should be further management of this patient. Either there should be any second surgery, superior rectus resection, MR recession, contralateral inferior oblique recession, or botulinum toxin for inferior rectus.
Lot good has been done,
Yes,
and my feeling would be to keep the first observation, first option. Keep her under observation. She is not having any double vision
ji sir.
in any
There's no.
direction. She doesn't seem to be having that cosmetic blemish,
Yes, sir.
which is very visible. Of course, ophthalmologists can always pick up the things which others won't. That's a bad thing about that, a good thing about that. If it gets worse, then option would be, suppose we have observed her and 6 months have gone and still picture is the same, and we want to do something because we are paid to do something. So, so there is a pressure. I think I would go for the safer thing, and that will be the last thing here, botulinum toxin, and see the result of it.
Yes.
If it gives us something positive, then I will go for the night surgery.
Thank you so much, sir.
Thank you so much, sir, for your suggestions. And thanks, Dr. Mariam. Now, for the last case of this scientific session presentation, I like to invite Dr. Asma. She is first year resident, FCPS postgraduate resident.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Asma Mahmood, PGR Ophthalmology, Gurki Trust and Teaching Hospital. Today I'll be presenting a case in this OSP clinical meeting. My patient, a 35 years old female, a housewife by occupation, a resident of Jallo Moor, presented in our OPD on 9th of November 2022. She presented with the complaints of blurring of vision in both eyes since the past 4 days, associated with headache since the past 3 days. The patient was in her usual state of health 4 days back when she experienced blurring of vision, which was gradual in onset, progressive in nature, and continuous throughout the day. It was associated with strain in both eyes, but there was no history of redness, watering, or any discharge. Headache also started 3 days back, which was generalized and dull in character. She also experienced flu-like symptoms since the past 1 week. In her past history, there was no history of migraine, sinus, or any skin disease. The patient was non-diabetic, non-hypertensive, and she had no other medical problem. Her past surgical history included history of 3 cesarean sections, which were uneventful. Her past ocular history was insignificant. She had insignificant family history for any medical condition. She belonged to a lower middle socioeconomic class. patient was non-smoker and there was no history of drug abuse or alcohol intake. On her general physical examination, the patient was well oriented in time, space, and person. The rest of the general physical examination was normal. Her systemic examination was also normal. In her ocular examination, her visual acuity was finger counting 1 meter in the right eye and 6 by 60 in the left eye. Her best corrected visual acuity was 6 by 60 in the right eye, while there was no improvement in the left eye. Her near vision was less than N24 in the right eye, while it was N24 in the left eye. Her intraocular pressure on Goldman applanation tonometer was 16 millimeter of mercury in the right eye and 17 millimeter of mercury in the left eye. Her pupils were sluggish to light in both the eyes. Her color vision showed red desaturation in both eyes. The light brightness sensitivity appreciation test was decreased in both the eyes, and her extraocular movements were full in both eyes. Her cornea and conjunctiva were clear in both eyes, while the anterior chamber was deep and quiet in both eyes. Her iris and lens were normal, while the vitreous was acellular and formed in both eyes. Her visual fields on confrontation method were normal in both the eyes, while her fundus examination revealed multiple findings. As you can see in the fundus picture of these patients, in both the eyes, there are multiple large, deep, yellow to white, flat lesions present in the posterior pole. As you can clearly see, these lesions are deep and they are located beneath the retinal vessels. The optic nerve contour is blurred, while the optic nerve contour is disrupted and the margins are blurred, which shows peripapillary elevation. While there is altered foveal reflex in both the eyes, which may explain the decreased vision of the patient. On the basis of history and detailed examination, a working diagnosis of posterior uveitis was made, which also includes white dot syndromes. These are some of the disorders that can be differentiated on the basis of their clinical presentation and fundus pictures. The characteristic morphological features of the lesions present in our patient favors the diagnosis of acute posterior multifocal placoid pigment epitheliopathy. For further confirmation, certain investigations were done. These are some of the infectious causes of posterior uveitis in which the patient may also present with white lesions on the fundus. And these should specially be ruled out before we begin further management of the patient. Following lab investigations were done to rule any infectious cause. All of these lab investigations were normal. Ocular investigations were done to further confirm our diagnosis. Her CBC and ESR was normal. Mantle test and X-ray chest was also normal. On her B scan of both eyes, the vitreous is anechoic and the retina shows multiple very shallow serous attachments at posterior pole involving the macula. Choroid and sclera are normal. Optic nerve and other orbital contents are also normal. As you can see in the optical coherence tomography of this patient of the right as well as the left eye, there is disruption of the retinal pigment epithelium in both the sides, while there are pockets of fluid in the intraretinal and subretinal space. On the basis of detailed history, examination, and investigation, a diagnosis of acute posterior multifocal placoid pigment epitheliopathy was made. Usually, it's a self-resolving disease with a good prognosis, but since there was macular involvement in our patient, so we gave him a suprachoroidal injection of triamcinolone acetate in both the eyes 2 days apart. It's a new and novel and recommended technique for posterior uveitis disorders, which shows promising results with less side effects. Visual acuity gradually improved to 6 by 9 in each eye on successive visits. Follow-up fundus examination and OCT showed resolution of lesions. As you can see on the follow-up OCT after 8 weeks, the RPE is no longer disrupted, while there are no more intraretinal and subretinal pockets of fluid. These are the OCT of the patients before the steroid injections and after the steroid injection for comparison. You can clearly see there's drastic improvement in the intraretinal and subretinal pockets of fluid. I thank you all for your patient listening.
Any suggestions or questions from the audience, please?
Very well presented, a good case. Posterior segment में तो जाते हुए वैसे ही लोगों की तारीफ आप लेते हैं तो आपने इस पर की ये बड़ी बात है. My suggestion is that when you make a list of provisional diagnosis, you keep the diagnosis which is most probable at the top, not at the second or third or fourth. And when you discuss the differential diagnosis, you give one or two arguments in favor of why you diagnosed this one and why you rejected the other one. So you have a list of 4 or 5 provisional diagnoses. So why you did not consider the other diagnoses relevant? So you have to give some argument. So otherwise, well done. You are right, sir. As a matter of routine, we always give argument in favor and against the probability. So it should be our routine.
यूएसबी लगाइए डाटा फौरन कॉपी करना है इसको ये डाटा कॉपी करना है यूएसबी ये हमारी प्रेजेंटेशन आपको डाटा कॉपी करना है ये वाले रिसेप्शन में इसको कॉपी करना है इसको या प्रेजेंटेशन दो है ना
Adil?
यही करनी है प्रेजेंटेशन चार्जिंग लगी बहुत चार्जिंग उसको रिमूव स्लाइड स्लाइड ठीक है
Hello.
In the meantime, we are honored to have the presence of Joint Secretary OSP Lahore Branch Dr. Khwaja Khalid Shoaib and President OSP Lahore Branch Professor Moin Yaqeen Sahab. Sir, I welcome you all. Now, from the clinical presentations of the postgraduate residents, we move on to the next session of today's clinical meeting. In this, we have a video talk of Dr. Amin Marashi. He is a Syrian vitreoretinal consultant. We'll proceed with.
Hello, this is Dr. Amin Marashi, retina specialist from Aleppo, Syria. I am presenting today the clinical application of OCT and OCT angiography in macular diseases for diabetic retinopathy and macular edema. Let's begin with the OCT features in diabetic macular edema and diabetic retinopathy. So when assessing the OCT for diabetic macular edema, the most first thing we should assess is the presence or absence of vitreomacular abnormalities. In cases we do have vitreomacular abnormalities such as epiretinal membrane or vitreomacular traction, we should assess the focal attachments of the inner retina with the macular thickening. If the case is prominent that the tractional element is responsible for the increased thickening of the macula, then we should consider pars plana vitrectomy with or without island peeling. On the other hand, if there are cystic changes with the coexisting epiretinal membrane, especially the stage 1 that is mild and not causing significant macular thickening alternation, then we might consider VEGF blockade agents or steroids intravitreally if we confirm the microaneurysmal leak on the fundus fluorescein angiography. However, if this strategy failed to improve the macular edema, then we should consider again the pars plana vitrectomy. But in cases with diabetic macular edema presented in the absence of vitreomacular abnormalities, then we should assess the location of the edema. Is it central? Then we consider intravitreal injections. If it's not central and clinically significant, then we consider laser treatment. Another important thing we should assess on the OCT is the presence of the biomarkers that can give us a clue about the visual prognosis, like the integrity of the ellipsoid zone and external limiting membrane, which if it's disrupted, it will have guarded prognosis and along, of course, with disorganization of inner retinal layers. And if there are not the integrity is not disrupted, then the prognosis is good. So typically in diabetic macular edema, we have increased macular thickening with a loss or without a loss of the foveal pit, depends on the type, and intraretinal cystic changes that those cysts can be empty or non-empty continent, and it can be presented with hyperreflective foci or even clusters of hard exudates that typically or usually cast a shadow artifact. On the other hand, we might see a cotton wool spot that is obviously looks like an increased irregular thickening of the retinal nerve fiber layer that may cast some shadow artifact and subretinal fluid. The diabetic macular edema types or can be presented as diabetic cystoid macular edema, usually presented with cystic changes, loss of foveal pit with or without subretinal fluid. On the other hand, we have the sponge-like diabetic macular edema, which typically appears like a sponge, usually contain empty and non-empty cystic content, and we might have a diffuse thickening without intraretinal cystic cystic changes with or without subretinal fluid. Should always search for vitreomacular abnormalities that I will talk in details in the next. OCT does a great job in determining the exact location of the diabetic macular edema, but this should be assessed using tomography and not topography. As presented in this topographical image, we can see that the diabetic macular edema is in the outer and inner subfield, sparing the inner central circle. But in real time, the tomography for the same patients showing us the increased thickening and cystic involvement of the central fovea. Hence, the tomography will give us a more precise information about the location of the edema. As in this example, we can see how the edema is located along with hard exudates outside the center of the this is the topography of the same patient, showing us the increased macular thickening involving both the inner and outer fields, and it is more than one disc size. This is how should we deem the clinically significant non-central diabetic macular edema. In contrast, when the diabetic macular edema is small or smaller than one disc diameter and involving the only outer fields, we deem this edema as non-central, non-significant macular edema. Hence, those edema warrant no treatment and only follow up with glycemic control. The topography serves a very good when showing the patient how the treatment improved and how the edema responded to treatment. And also, the tomography is a good to show us the structural changes after the treatment. As stated, the tomography does a great job exclusively when demonstrating the patient how was the edema and the location and how it was after treatment. However, the tomography here it show us the efficacy, but it show us also how the structure responded to the treatment, and show us how we have the disruption of the ellipsoid zone can explain that the patient why didn't have a perfect vision after the treatment. Please note one thing, that the relation between the macular thickness and the visual acuity is modest because there are several biomarkers that can involve or can affect vision. For example, here we have disorganization of inner retinal layers, we have disruption of ellipsoid zone and central hard exudates, which all both can affect vision despite the modest increased thickening of the macular edema. This is only appreciated using tomography and not topography. Now let's talk about the vitreomacular abnormalities. We here and epiretinal membranes causing pegs and corrugation of the inner retinal tissue, along with vitreomacular traction that causing this tractional plate doing anterior-posterior traction of the retina, causing its on the other hand, sometimes the epiretinal membrane, as presented here, like stage, especially in stage 1, can be only laying there without causing any significant disruption. And hence, we can see here an intraretinal cystic changes mainly located at the outer nuclear layer. So in those examples, if we do a fundus porcine angiography, most likely we can find a leaking microaneurysms, and those patients may benefit in injecting intravitreally rather than doing prosplana vitrectomy. Sometimes it can be a mixed pathology. As we can see here, there is an epiretinal membrane, we have intraretinal cystic changes, so it is more a mixed pathology, and maybe we need not only intravitreal injections but also surgery after subsiding the edema. However, the topography for the same patient, we we can see both serrated borders, which indicate or depict the areas of the traction, and smooth borders that can depict or show the location of the edema, where the vascular element is most likely. But we shouldn't rely again on the topography itself. We should depict this or prove this with doing fundus fluorescein angiography. So what are the main biomarkers we can see on the OCT? The hyperreflective foci, they are usually an activated microglia, and they may surround the cyst, doing the pearls and pearl necklace sign that itself can indicate a diffuse leakage. And we have the disorganization of inner retinal layers every 299 micron affected. Can For 4 months we can lose one line of vision. But keep in mind that disorganization of inner retinal layers is not a fixed biomarkers, as the vision may improve with time if we keep the macula dry. And we have the ellipsoid zone and external limiting membrane disruption, which is an independent biomarker that can affect vision, and affecting the vision independently from the disorganization of inner retinal layer, and unfortunately it is irreversible damage. In diabetic retinopathy and its complications, the OCT can show us the vitreous hemorrhage, sometimes as a cluster of hyperreflective foci in the vitreous cavity, and pre-retinal hemorrhages that contain smooth borders and cast shadow artifact. And usually it can very helpful to detect if there is coexisting diabetic macular edema, which will affect our treatment strategy. And in cases of a tractional retinal detachment, it can show us the tractional fibrovascular tractional element and the epiretinal membrane. It can show us sometimes the coexisting vitreous hemorrhage and the corrugation of the inner retinal layers. And sometimes it can be very helpful to show us if the traction is threatening the fovea or not, if that is somehow hard to judge on the clinical examination. Now we're gonna shift to the OCT angiography for diabetic macular edema and diabetic retinopathy. The microaneurysms usually do not show any leakage on the OCT angiography, because in contrast to fundus fluorescein angiography, which is it studies the dynamic flow of the blood, the OCT angiography studies the contrast motion of the erythrocytes. Hence, microaneurysms will appear dilated in saccular shape, and microvascular alternation can be depicted in both superficial and deep capillary plexus, and we can depict more in deep capillary plexus, which the OCT angiography give us the ability to study the structural vascular changes at the level of the deep capillary plexus. In contrast, the fundus fluorescein angiography only studies the superficial capillary plexus. So hence, as it does not show any leakage, it allows us to study the vascular network, which will appear delineated in the OCT angiography when it comes to the neovascularization elsewhere or in the optic disc. Some cases of the neovascularization can appear next to the irma. Let me show you an example here. This is a neovascularization elsewhere adjacent to an area of non-perfusion. But it's very important to look at the OCT scan overlay, which shows us those decorrelation signals depicts a neovascular activity. And here we can see how it is adjacent to an irma, which is located in the inside the retinal tissue, and the neovascularization will appear at the hyperreflective membrane that is attached to the inner retinal surface. So The peripheral non-perfusion is a very good studied in the OCT angiography. However, the OCT angiography can show us both the neovascularization and the areas of non-perfusion, but due to the lack or the most machines of the OCT angiography lacks the panoramic photograph ability and their narrow field, we usually need to stitch those images together in order to generate those wide field, except for some new swept source machines that has the ability to do this wide field imaging. But still, wide field fundus fluorescein angiography excels in showing the active neovascularization more accurately in the periphery. This is the OCT angiography for the patient, and this is the same patient but with fundus fluorescein angiography. And as you see, just one click, one image, we can depict all. Okay, so when it comes to foveal avascular zone, the FAS, the OCT angiography does an excellent job in studying the changes of FAS in both deep capillary plexus and superficial capillary plexus, where fundus fluorescein angiography only shows us the changes in FAS in superficial capillary plexus. But the OCT angiography revealed that in diabetic individuals without diabetic macular edema, they show the enlargement of FAS despite the absence of the both diabetic retinopathy or diabetic macular edema. Another important feature of the OCT angiography is that when studying two FAS, not only it shows us the FAS changes in multiple layers, the deep and the superficial capillary plexus, it also shows us the irregular outlines and the gaps in both superficial as presented here and the deep capillary plexus, as the fundus fluorescein angiography shows only the superficial capillary plexus, and it cannot be used to quantify the changes because of the staining and leaking at the late phases of the fundus fluorescein angiography. On the other hand, due to the absence of leak, the OCT angiography can easily studies the quantitative analysis, and this applies also for the neovascularization. A word when we only assess the OCT angiogram in patients with presented with diabetic macular edema, we might falsely deem this case as a diabetic macular edema with ischemic maculopathy. In reality, if we take a more look at the structural infas OCT and see the segmentation line here, we can easily assess the segmentation artifact, which caused a signal void due to the cystic expansion that caused this abnormally enlarged foveal avascular zone. This is more appreciated in the deep capillary plexus, but after treatment, we can see how the diabetic macular edema has regressed and shifted to non-central. We can see how the ischemic changes that we deemed, and it wasn't an ischemic changes, it was only enlarged FAS due to signal void from the cystic changes, how the FAS has retained a normal size in both deep and in superficial and deep capillary plexuses. So hence the in cases of diabetic maculopathy that are associated with ischemia, like this example, when we look at the OCT angiogram here, we see an enlarged foveal avascular zone with gaps in the OCT angiogram. But when looking at the OCT B scan here, we truly see there is no diabetic macular edema, not even in the structural infas OCT, not in the deep capillary capillary plexus, not in the superficial capillary plexus, without any kinds of artifacts such as segmentation artifact. Another important thing when we're gonna assess the OCT angiography, we always should look at the B-scan OCT, the decorrelation signal, the embphus OCT, the structural, of course, embphus OCT, in order to depict the real underlying pathology first, and to rule out any artifacts like motion artifact, like masking artifact or shadowing artifact. To learn more, scan this QR code or see the link in the description below.
On a topic which was sort of on medical education. And this is something which is critically a new thing which is going to come forward in CPSP training, that is work-based place assessment. The way forward, CPSP already has assessment tools in the examinations, which include the exit exam. You've got the IMM, and you've got the final FCPS exam, and obviously for your entry exam you've got the FCPS Part 1 exam. Now the question is, the competency model says that by the end of the training, when you come out, are you a safe doctor? That are you able to handle everything which it takes to manage a patient? Things are, when you're taking an exam, you take the exam in an artificial setting and a simulated setting, so you are geared to perform good at that time, but your actual attitude, your professionalism, your skill is actually shown much more when you're working in your own environment, which is a workplace based place. And that is why they say, if you observe somebody and he's able to pass the work-based assessment exam, then he will be able to perform is good in the real world scenario. So there are different models. The CPSP uses this model, having initially the you can see the main thing which they want is good patient care with the competency-based model, and then you've got all the layers makes a comprehensive doctor. And similarly, the Americans have got the ACGME model, and everything starts with a medical knowledge, and you've got medical expert. This is the CanMeds model of the Canadian of Medical Association. So what is CPSP currently doing? So the work-based assessment is currently present in the CPSP, the curriculum or the booklet you see. It's currently the ways they've identified through which you can assess residents is mini CX and DOPS. यहाँ पे resident कितने हैं? उनमें से मिनी CX और DOPS का नाम किन्होंने सुना हुआ है?
हमने सुना सारों ने हुआ और किया भी है सारों ने हुआ वो। चले गुड, फिर तो अच्छी बात है। अगर आपको पता है तो then I don't need to say much on this thing. So but they are present, but currently are they being done? आप लोग करते हैं ज्यादा डॉप्स और मिनी सी एक्स अपनी रोटेशन में या नहीं करते हैं? करते हैं लेकिन ऑफिशियली रिकॉर्डेड इट डजंट गो टू द एग्जामिनेशन बॉडी। एंड जो करते हैं क्या, डू यू हैव अ लिस्ट ऑफ व्हाट यू वांट टू डू और व्हाट इज द प्रेफर्ड लिस्ट, वो आप फॉलो करते हैं? ये वो भी प्रॉब्ली हम भी नहीं करते एज सच, लेकिन हम आई डोंट नो अगर आप कर रहे हैं तो विच इज हाँ। So usme we had a meeting. Carl Golnick was here in Karachi, and when the CPSB was having a medical education conference, so we deliberated on all the topics of mini CX and DOPS, which are essential and which should be included, and we came up with a list that which I'll go through. So currently, um, the topics which are included for mini CX in the curriculum are given here, and then you've got the year 4, and some of them, when we are going through them, some of them seem more sort of unrealistic to achieve, and some of them did not seem to be very adequate, in which we're trying, like electrodiagnostic tests. Probably you can see them, but you cannot do them because they are not present in all the departments. That was one thing. And the current mini CX form which they have is included this way. So in this, what you can see, the grading of the interviewing skills, symptomatic progression, you've got justification of action, professionalism, but it does not give you any bit of how the patient actually was examined and the examination skills, your interpretation skills, how they were done. So this was something which we thought was deficient in this. The other things is direct observation of skills. We went through the Royal College of Ophthalmology recommended list. They've got one thing which is called the clinical rating scales, in which they've got tasks, and then they've got more skill tasks, which are things which you do in the operating room. So I'll stepwise go through that, and this is the current DOP slips, which was included in the sync, which included asepsis, YAG lasers, retinal lasers. Then you can see year 4 was making ports in vitrectomy. That was something we thought is not very applicable for training in that sense. Cryo is there, but how many people actually will be exposed to cryo? So the current DOPS form was in this form, in which you can say he introduces the topic, and then he goes in how he actually explains the topic to the patient, and then how this asepsis is done, how the procedure is actually done, and then how the follow-up to the patient is given. Whenever these two forms are used, they're always feedback to the student. So it's more or less a formative assessment form. So the main aim of both of these forms is that by the end of this, a student should be ticked off or certified by his supervisor that he's good enough to pass this and this is okay for him. But it was to be decided which year should he pass this, and it, what if he does not pass this, what to do. So the thing is, if it's a formative thing, you ask them to do it again and again until they pass it, and you decide at which level it is appropriate to pass this one. So we decided over different topics which were included in the mini OC. Instead of using a doc, the mini CX, we were referred to another form which is called the ICO OCX. Carl Golnick, he's a medical educationist who's been here with us. So he introduced this form, and you can see this form includes different areas in which you can see it's more oriented towards being sort of a long case or a short case examination, which you're typically exposed to in a final FCPS exam. So this gives you a true feeling of if the patient of the student has actually learned the skills and what his abilities have developed. So you can see the other thing which is important about this, that this is not just a form which just gives you yes or no or grade 1 to 5. It actually divides you into three different categories, and then it is defined that who is a competent person, and you want the person to pass a competent state. You are not making an expert. ये नहीं है कि मैं बहुत अच्छा और इतना अच्छा कि मैं प्रोफेसर से भी अच्छा, वो वाला आप कैटेगरी में नहीं लाना चाह रहे, क्योंकि it takes a lot of time to build an expert. You're there only in 4 years to build a competent person. So इसमें देखें ये चीजें आपकी जो normal आप examination skills there are included in this form. So and this is the OCX3. So then you also check for empathy, the respectfulness, explanation, and the things he does, and then case presentation, his clarity, his differential diagnosis, appropriate plan. So everything is actually included in this. So the main clinical steps are included. So this is like having a proper long case recorded by your supervisor with you every half yearly or quarterly. That will, if you do a 3 or 4 cases and different specialities, that will give probably a good feel for you, for the exam, and to your supervisor for how you're actually placed at that time. So this was the plan and orbit. So you can have an OCX and orbit at an axis, then on external eye, and then on a glaucoma, and then posterior segment. So if you divide this way, this is how your FCPS is oriented as well, and you will get a good orientation. So the current DOPS form is, which we decided was, can be used as it is. It is only the topics which we needed to define. So the list of DOPS topics which we finalized was as ocular surface foreign body, removal of sutures, lacrimal syringing. These are first two are in the first year, then intraocular and periocular injections, the second year, then local anesthesia, ocular orbital ultrasounds in third year, and then YAG laser and argon laser for retinal problems. This is fourth year. And this is going to be judged on this form on DOPS. So if I just show you the DOPS form, the main thing was you ask the patient, you explain the patient what you're going to do, then you do the prep for the procedure, then you do the anesthesia, you observe the asepsis step, then the steps are done correctly. If there's any problem, you ask for help. The important thing is the assessor's satisfaction, then the resident satisfaction. So the both are concurrent with that. And the thing is, ये नहीं है कि supervisor फिर रहा है कि ये this is something which you need to complete. It is the resident who comes into the supervisors and says that we have to complete this to get ourselves certified, to please sit with us and plan this and do this for us. So if it is done in a quarterly fashion, you can have a teaching day on a session that in this you have assessment, and that can be easily done on that area. The the final thing was the complicated task, which is the objective surgical assessment rubric, which we recommended to be used, the phacoemulsification rubric, the ICO Oscar, which has got, I think, 14 steps, which tells you different steps of cataract surgery, including placing the speculum, then making the incision, CCC, then surgery, then at the end of the procedure. So there are different steps, and then there are sort of global indices which are used, such as centering the microscope, handling of instrument, communicating with the nursing staff. So it is divided into that. So we said, let's go see this rubric in place. The residents have it from first year, and by the end of the fourth year, they need to sort of qualify for this. And if they're competent enough in the rubric, we will say that they're competent to do cataract surgery. This is, I think, the most essential thing. If it is implemented, this will make sure that the person or the people who are passing the residency are surgically competent as well, because this is one final tool which is going to be very important. So the implementation plan, what came up finally was the OCX 1, 2 in first year, and year 2, 3, and 4, and then DOPS 1, 2 in first year, and 3 or 4 in second year. Then OCX FACO can be done in each year, but then you have to sort of certify at the end of third year or fourth year, and the DOPS and keep going on until the third year and fourth year to a higher or a complex level. So like the retinal laser that is done at the end of third or fourth year rather than the other end. So this is the basic plan which the CPSP, their the ophthalmic the the committee which decides on their curriculum, they approve this, and this is being sent to the CPSP council, and they think they're planning to have it implemented from somewhere June or July, depending on what happens today after the elections. But this is what they have in plan, and I think it's a good thing if we can get this in our curriculum. And Carl was there, and he thought if you can have it and you can run this, this could be one of the best the residency programs in the world. Any questions? I'll be happy to ask. Thank you very much, everyone, for patiently listening with us.
अब वो घड़ी आ रही है जिसका सब रेजिडेंट्स को था इंतज़ार। जो आपके सामने प्रेजेंटेशंस की गई उनका रिजल्ट तैयार है। सो आई विल लाइक टू इनवाइट डॉक्टर ख्वाजा खालिद शुएब सर, जॉइंट सेक्रेटरी OSP लाहौर ब्रांच। सर प्लीज कम हियर एंड अनाउंस द रिजल्ट्स प्लीज।
थैंक यू वेरी मच फॉर इनवाइटिंग मी। एक तो ये ख़बर थी कि जो मैं आपसे शेयर करना चाहता हूँ कि CPSP की जो ऑफ्थमोलॉजी की फ़ैकल्टी है उसमें पंजाब से 2 सीटें थी। तो मैं और प्रोफेसर जाहिद साहब हम अनअपोज सेलेक्ट हुए हैं, तो किसी और ने हिम्मत ही नहीं की है अपने पेपर डालने की। तो जिस तरह मोइन साहब ने कहा, ये CPSP की ऑफ्थमोलॉजी फ़ैकल्टी इस पे डेलिब्रेट करती रही है और करती रहेगी कि क्या क्या चीज़ें हमने इनकॉर्पोरेट करना है। तो अगले 4 साल इंशाल्लाह मैं भी इसमें पार्ट प्ले करूँगा मोइन साहब के साथ। मैं सिर्फ 2-3 मिनट लेना चाहता हूँ। बड़ा इंपॉर्टेंट टॉपिक उन्होंने दिया मोइन साहब ने कि हमारा ये कमेंट होते थे यार FRCS करके आ गया, इसको अपेंडिक्स करनी आती नहीं, या FCPS कर लिया इसने, फेको तो इसको आती नहीं है। सो जो हम एग्जामिनेशन के बाद एक्सपेक्ट करते हैं क्या क्या चीज़ें आनी चाहिए, तो ये स्कॉटिश ने कहा, जो स्कॉटिश डंडी वालों ने, फिर अमेरिकन ने कहा, फिर कनाडा वालों ने कहा, पहले लिस्ट बनाए क्या क्या चीज़ें डॉक्टर को आनी चाहिए जब वो फील्ड में जाता है। तो हिस्ट्री लेनी आनी चाहिए, एग्जामिनेशन प्रोसीजर्स करने आने चाहिए, ऑपरेशन करने आने चाहिए। तो जो जो चीज़ें करनी आनी चाहिए उनको कॉम्पिटेंसीज का नाम दे दिया, और ये चीज़ें एजुकेशनल सिस्टम में उनको पढ़ानी चाहिए। अब ऑपरेशन किसी को मौका मिलता है, किसी को नहीं मिलता, तो फिर ट्रेनिंग तो पूरी ना हुई। और आप FCPS का एग्ज़ाम दे के आते हैं, उसमें फेको तो कराते नहीं हैं, तो कैसे पता चलेगा कि ये कॉम्पिटेंट है, कि ये कॉम्पिटेंसी उसको आई कि नहीं आई। सो अब कॉम्पिटेंसी बेस्ड मॉडल ये है कि जो जो उसने करना है उसको सिखाएं और उसका एग्ज़ाम भी लें। तो ये सारी बातें मोइन साहब ने पेश की। सो कमिंग टू द रिजल्ट्स, ज़बरदस्त प्रेजेंटेशन थी, लेकिन जजेस ने ये डिसीजन दिया है। तो मोइन साहब को मैं कहूँगा आ जाएं, और सलीम साहब और आप भी आ जाएं। और द थर्ड पोजीशन इज शेयर्ड बाय नाइला हनीफ एंड अहमद याशर खान। तो पहले अहमद याशर खान साहब आ जाएं। अहमद याशर खान
on first position we have Asma Mahmood. और ये हमें सर्टिफिकेट सपोर्ट बाय मेडल हाँ जी बैठे आज और वो लेक्चर साहब को प्रेजेंट करेंगे मुझे ये हमारे सीनियर मोस्ट प्रोफेसर